Good morning, and welcome to Medicine Grand Rounds. This is a special Grand Rounds in that this is one of our Chair's Distinguished Speaker Series or Dream Speaker Series Grand Rounds. Emily Jochum, our Chief Resident and a future nephrologist who's going to be actually trained here starting next year in nephrology, identified our speaker today, Dr. Jane Schell. Dr. Schell grew up in New Orleans and attended undergraduate at the University of South Alabama in Mobile, and then the University of Alabama in Birmingham for her medical degree. She then went on to Johns Hopkins for that illustrious residency, and then to Duke University for fellowship in nephrology. She undertook a clinical research training program, master's in health sciences, while at Duke as a fellow, and also took a fellowship in hospice and palliative care. Since 2012, she's been assistant professor of medicine in the Department of Internal Medicine at University of Pittsburg Medical Center in the Division of Renal and Electrolytes. She's published 25 original publications, reviews, and invited papers, as well as chapters, with a focus on nephrology, of course, and communication and teaching. Two titles of note in the last couple years are supportive care communication strategies to improve cultural competence in shared decision-making, and communication skills for dialysis decision-making and end-of-life care in nephrology, certainly in line with her training. She's been funded by the Patrick and Catherine Weldon Donahue Medical Research Foundation and had took part in the William and Sandra Bennett Clinical Scholars Program for a 2-year funding stint there. She's an active educator, nationally working in programs such as Teach Each Other Well, which she co-developed, and this is an interactive communication session for nephrology attendees at the National Kidney Foundation meetings. She's also been involved in really developing and co-instructing the NephroTalk 3-day communication skills workshop for nephrology fellows, and she's also working to train the trainers. In addition, she's worked with the Harvard Nephrology Communication Skills Workshop. At the University of Pittsburgh, she's an active educator at the medical student, resident, and fellow levels. She's also a good citizen nationally in terms of participation with the National Kidney Foundation, the American Society of Nephrology. She's on the editorial boards for the American Journal of Kidney Disease and the Clinical Journal of the American Society of Nephrology. She's received a number of awards, including the Leonard Toe Humanism Award as a medical student, the Norman D. Anderson Award for Ambulatory Care as a resident, and the Duke Fellow Teaching Award as a fellow at Duke. She's given a number of presentations nationally for the American Society of Nephrology, the National Kidney Foundation, the Renal Physicians Association for Advanced Practitioners, and the Council of Nephrology Social Workers Conference. In addition to that, she's given a number of visiting professorships and grand rounds at institutions such as the Medical University of South Carolina, Lenox Hill Hospital, Duke, University of Michigan, and the University of Pennsylvania. But never before has she been a dream speaker. So today it's really my pleasure to introduce Dr. Schell as she provides grand rounds entitled Updates in Nephrology, Matching Treatments with Patient Priorities. Welcome, Dr. Schell.
Thank you so much. Well, good morning, everyone. I have never received such a lovely invitation, number one, from Emily, and also introduction. So I thank you all for having me here, and I look forward to talking with you about some of my passions in nephrology and palliative care. I came in late. I had a couple flight delays, and my Uber driver really introduced me to Madison last night. I learned so much. I learned that you made it to the Sweet 16, that your Capitol building is one of the largest ones in the nation, that State Street is this long road that's really for college kids to walk and have fun and many other things. And so I felt very much welcomed by my Uber driver and so much more this morning. So I want to talk to you today as a physician who takes care of seriously ill patients, as many of you. I'm going to highlight some of my experiences and use my kidney knowledge as a model, but I'm hoping by the end of this talk that you will take some pearls with you to think about how to incorporate palliative care skills into your practice. And so my talk is Update in Nephrology, Matching Treatments with Patient Priorities. And when I think about how I started out as a renal palliative care doctor, I didn't wake up that way. It came in my first year of nephrology fellowship. And really, to talk about my journey, I need to talk about a lot of patients that I met. And one in particular that crystallized the palliative care needs I learned in nephrology was the first patient I met. His name was Henry. I met Henry shortly after he started dialysis. As a first-year nephrology fellow, learning fluids, electrolytes, access, dialysis orders, I met Henry. He was hospitalized many times, actually, related to access problems, volume overload. Eventually, he started having diabetic foot ulcers and worsening peripheral vascular disease, prompting hospitalizations that led to antibiotics, eventually amputation. And I started watching Henry's decline. He had pain. He was less interactive, a less dry sense of humor as I remembered in July when I had met him. He was hospitalized again, losing weight, eventually went to a nursing home. And by the spring of my nephrology year, I started noticing what my patients were experiencing, specifically for Henry. And I saw the decline. The last time I took care of Henry, it was almost at the end of my first year, and he was intubated with multi-organ failure. And I felt very clear that I had seen his decline. And when the ICU team asked me to participate in a family meeting, I said, oh yes, and of course. And I sat across the table from his family, and as we talked about shifting goals of care and even thinking about dialysis withdrawal, we were met with shock and surprise and anger. And so Henry died before he could get to his next dialysis session. And as I thought about Henry's experience and many of the experiences I faced with my patients, I was left with more questions than answers. And these are the questions that sort of have guided my now practice. And one was, what did Henry even know about dialysis? Did he know what to expect? And were there other treatments we could have offered him? How could we have better addressed his symptoms and his needs over time? And finally, what could I have done, what could we have done to ensure that he and his family had a quality end-of-life experience? And so the next 40 minutes or so, what I hope to do is share with you a model for applying palliative care to chronic illness. I'd like to think about what each one of you does, whether it's specialty or general medicine, and how to apply palliative care into your practice. I'm going to talk about my experiences and my discovery into learning about palliative care and nephrology, and specifically talk about 3 ways that we can improve palliative care in the care of our patients. And first of all, talking about conservative care. Secondly, trying to find opportunities to help with symptom management and advanced care planning. And identify opportunities that we can reassess the care plans and goals of care in a timely manner. And I'm going to close with talking about my educational experience and what we're doing in nephrology. So to begin with, talking about palliative care and kidney needs. I think it's helpful, although many of us, because you have such a strong palliative care department, we know the definition of palliative care, but it's helpful to look at it and think about it. So palliative care is a specialized medical care for people living with serious illness. There's no words about prognosis, there's no words about terminal illness. And I want you to think about palliative care not as a team, but as skills, because I'm going to be encouraging you to use your palliative care skills. And what it's intended for is to relieve symptoms, to relieve stress of living with serious illness, to improve quality of life for patients and family, and that it's provided alongside life-prolonging care. So we're not limiting care, we're actually adding care. And that for palliative care to work well, we need to think about it early. And so in this model, in this model, we need to be thinking about palliative care needs from the beginning at diagnosis, and how over time patients' needs become greater, and so that palliative care becomes all the more stronger and leading to helpful transitions when we are looking at end of life. And finally, bereavement for our caregivers. And with that backdrop, I want to talk about kidney disease. You knew that was coming. So as many of you know, especially our internal medicine residents, our patients who are starting dialysis are older. We are, the age group of greater than 75 has become the fastest group of people starting dialysis in the United States. And this is a study that Manju Karela did back in 2007, and it looks at dialysis initiation rates by age group. And on the x-axis, you have age groups from 65 all the way over to 85. And then she looked at how initiation changed over time, starting in 1996 with the dotted line at the bottom, and then ending with 2002 and 2003, the solid line at the top. And what she noticed was that even when you adjust the data for growth population, we have increased the dialysis initiation for patients over the age of 80 by 57%. So many of these patients are starting on dialysis. Many of them are coming with their coexisting conditions that often influence how they do. In this one study, the patients over 80, their one-year mortality was about 50%. And so end of life is just a part of what we do as nephrologists, and many of us when we think about the other diseases we are facing. And our patients have symptoms. In fact, dialysis patients have comparable symptoms to those of cancer. This is a study that was done in 1990, which most studies have found the same results, is that dialysis patients have substantial symptom needs. And that's true for hemodialysis and also our peritoneal dialysis, which is meant by CAPD. And not only is it important that they have these symptoms, but it often affects their quality of life, their adherence to treatment, their ability to be in the world and live well. And oftentimes, psychological symptoms come up. In fact, 1 in 5 patients, whether they're on dialysis or not, have trigger-positive depression. So all of these important symptoms impact how they do. And so what became apparent to me is that my patients weren't exactly prepared for what it was like to live on dialysis. From survey data of patients who have and haven't started dialysis, there's limited understanding about what are the treatments. Many of them don't know about conservative treatments. And they often don't know about the risk and benefits of dialysis. And when I say risk and benefits, I don't mean about getting the catheter or the infections, but how is it going to affect my life? Finally, this high symptom load, they often are under-recognized symptoms and they're not treated. And finally, dialysis patients are very specifically known for a lack of preparation at end of life. Most patients haven't discussed prognosis with their nephrologist, and only 1/3, a little bit more than that in newer data, have completed advanced directives. And so when they're not prepared, it's not surprising that our patients experience the most intensive end of life. So this was a study of USRDS data, which is all of our dialysis data in the United States, looking at how patients over the age of 65 spent the last month of their lives, and then compared it to those that were Medicare beneficiaries with cancer and heart failure. And if you look in the first column at the dialysis patients, you'll see that 76% of patients were hospitalized in the last month of their life. 50% of them went to the ICU. 50% almost died in the hospital, with only 20% receiving hospice. And so if you look at that and also compare it to those with heart failure and cancer, you can see statistically and significantly our patients are experiencing an intensive end of life. And what surprised me and shouldn't surprise me is that this isn't how patients want to spend their time, right? I'm talking about kidney data, but this is the same whether we'd be talking about cancer or heart failure. In this study, they surveyed patients and families and had them rank their priorities. This was Australian data, and what they found was that the top 10 priorities for patients and families, nowhere in it was mortality. In fact, the way that they described survival was actually living well. And so you'll notice that they point out most important to them was fatigue, energy, resilience, coping, the ability to travel, the ability to do things, the time off dialysis. And this shouldn't surprise us. I think if any of us were patients, we'd be saying the same thing. And the other part of it is people often want to know what to expect, even when there is uncertainty. And so when they survey patients, most of them say, we want prognosis. Not all of them, but most of them. And they expect that we voluntarily divulge that information to them. And they feel it will help them better prepare. So as a second-year fellow, coming away from my experiences with the patients I cared for, I really became interested to find out why is there a disconnect? Why do patients want one thing and what their experience is different? And so I embarked on a qualitative study of older patients and nephrologists, and I really wanted to understand what were we talking about? What was happening in those moments that we were with our patients? So I interviewed 29 older patients with advanced kidney disease and those on hemodialysis and 11 nephrologists when I was at Duke. And I found 6 themes that described how communication was occurring and that it occurred across the disease trajectory. And so that even from diagnosis all the way towards moving towards end of life, there were palliative care needs that I saw. And speaking specifically for the patients, they described this strong shock by their diagnosis that really lingered even when they had moved on to hemodialysis days. Patients were uncertain about how their disease would progress, and they lacked preparation for living with dialysis, which really mirrored the data I just showed you. And I want to share with you some quotes because I feel like it helps bring home some of the meaning behind this data and what we're seeing. So patients viewed dialysis as a default decision. One patient that I spoke with, he looked back on his CKD days and he said, you know, they didn't really tell me what kinds of things to expect before. They just told me sooner or later you would go on dialysis to purify my blood. Patients described a strong mental and physical adjustment to living to dialysis. One dialysis patient told me, the situation I'm in, I think about it a whole lot because that's no way to live. It seems like I'm going around in circles. I watch these people that come to dialysis and I see that's the way I am. So you really sense the struggle that these patients are living with. Patients aren't planning for the future and they don't know what's coming up. Oftentimes in the dialysis unit, we check labs. I don't know if that surprises you. And so oftentimes when they're talking to patients, we're telling them about their labs. And so one patient reflected on that, and he said, you know, the only thing they say is functioning fine, but the function of what? I want to know what comes after this. And so you get the sense that there's a strong need for knowing about what's up ahead. And similarly, I want to talk about the nephrologist challenges because I don't think that we're doing something wrong. I think we're dealing with a really challenging disease. Again, whether we're talking about kidneys or cancer or heart failure. And nephrologists describe their own challenges. They really struggled to explain the illness complexity. They felt out of control themselves in managing kidney disease and also how their patients do. And finally, they tended to avoid talking about the future, especially when they didn't know what was up ahead. And so nephrologists tended to focus their treatment around dialysis preparation. One nephrologist described, you know, I try not to scare them on the first visit. If they're not facing dialysis right away, then I prepare them slowly. So they decide how preparation happens and is often focused on dialysis. They struggle to help patients live well on dialysis because they often can't predict how they're going to do. So one nephrologist said it well. He said, I think it's where I say I don't know how they might do is the hard part because I don't think we can clearly say how a person will do on dialysis. And so when we don't know, we often don't talk about it. And you can probably think about examples in our own practice. And finally, when there is uncertainty, prognosis is often not discussed. One nephrologist said, "I don't think we really talk about prognosis in our stable patients and nothing going on." So it typically happens when there's an acute illness or a crisis. And so as I looked back on my data and I thought about where do I see improvements and how we take care of our patients, I really thought about it from a communication standpoint. And the first thing, and one thing I want to talk about is I want to encourage us to talk about all of options for our patients, including conservative care, and ensuring that we're picking treatments that are right for our patients. And then how do we actively follow up on these conversations, even when there's uncertainty about how these patients do? How do we help them recognize symptom management and treat them, help their course, and also prepare for the future with advanced care planning? So I want to talk about two specific ways that we can encourage both conservative care, symptom management, and advanced care planning. And I want to talk about conservative care as a treatment option for advanced kidney disease. And when I talk about conservative care without dialysis, many of you may have your own definition of what that means and maybe what that means in your own specific field. But when I talk about conservative care without dialysis, it's a deliberate decision. It's a care path that we make often in the outpatient setting where we decide that we are going to actively prepare and treat our patients conservatively. And it's often with a goal to optimize quality of life, treat symptoms, and also prepare for the future. When appropriate, we also try to preserve residual renal function. But I put that at the last point because often some of the things I do to help preserve renal function doesn't always equate with goals for quality of life. And it's intended for patients who may not meaningfully benefit from dialysis therapies. And that may be because of other comorbidities, and it may also be from their kidney prognosis. And secondly, patients whose goals are really to focus on quality of life. There's many patients who I have met in my practice who their quality of life isn't going to change. It is what it is. They're blind from their diabetes and they can't play golf. And they don't want therapies that are going to prolong their life and add to their burdens. And so they're intended for conservative care. And why do I talk about this? So when we look at the UK, Canada, places outside of the United States, there's really deliberate, well-done pathways for conservative care. But in the United States, we're lagging behind. And this is represented in a recent study from Ann O'Hare in Seattle and Susan Wong. And so what she did was she went through VA data and she identified patients with a GFR of less than 15. So these would be patients that would be very soon into thinking about treatments. And what she did was she took away anyone who was on dialysis and just looked at the folks less than 15, not on dialysis, and looked at how they were planning or treated in follow-up. And what she found is, and if you look at this is by age group, starting at less than 45 all the way to over 85, is that the majority of patients, when they identified charts and found how treatment decision-making was occurring, the majority, even for those over 85, are either discussing, preparing, or now on dialysis. Okay? So less than 50% had made a decision to not do dialysis. And if you think about that, you think about these decreased opportunities for patients to hear about conservative care. And she adjusted it for comorbidities, and there was no difference. So even our very sick older patients were not hearing about conservative care. And I want to just compare this. She also compared the outcomes for who were starting on dialysis to other countries, specifically Canada and Australia and New Zealand. And what you'll see is that just over 40% of patients over 85 are on dialysis compared to less than 10% in other countries. So more of our patients are going on dialysis, and you get the sense that it could be in some of the ways that we're preparing them. And it makes a big difference. I want to name that when we look at mortality data comparing patients who decide conservative care versus dialysis, it's not great data, okay? These are retrospective studies, and at this time, looking at prospective studies are going to be small cohorts, and we don't have a lot of the data. So we try to learn from what we do have. And most of our data comes from the UK, Canada, and Australia. And this was a UK study that looked at 844 patients who either elected conservative care versus renal replacement therapy, which is dialysis. And what you'll find is that over in the left panel, patients with low comorbidity, they live longer with dialysis over the age of 75, okay, substantially longer. However, when they adjusted the hemodialysis patients for high comorbidity using the Charlson Comorbidity Index, there was not a substantial improvement in survival in those who did dialysis compared to conservative therapy. Another study looked at, well, how do these people live? And this also came out of the UK by Rachel Carson and authors. And what they looked at was specifically, so they lived longer in their study, but they wanted to see out of the hemodialysis patients, these are all patients over the age of 70, how did they spend their survived time? So you can look at the bottom bar here. These are the hemodialysis patients. There were 112 of them compared to 30 patients who were doing conservative care. Survival's here at the bottom, and you can see that patients lived substantially longer, about 33 months compared to about 13 months. But when you look at the dark gray and the speckled gray, this was time either spent in the hospital or receiving dialysis. So that if you notice, the majority of the survived time compared to the conservative group was spent receiving medical care. So it's important as we think about the patient priorities that we talked about at the beginning of the talk and look at how the experience can go. And so why consider conservative care? A lot of people ask me, well, Jane, how long would I live on conservative care? And I answer just like any doctor would, and I'd say, it really depends. And it does depend. It depends a lot on the renal trajectory. What has the creatinine been doing for the past few years? How much proteinuria is there? There is actually some medical things that can help me predict how they do. When we look at the data that we do have, there was a systematic review of 13 studies that found that patients, on average, live about 6 months to 24 months. So it may be longer than many of you are thinking that they do live. And why is that? So this is another article by Ann O'Hare, and she basically looked at GFR versus age groups and your likelihood for either starting dialysis or dying. And if you notice, at any GFR, older patients are more likely to die from something else than to start dialysis. And she actually looked at renal progression in older patients. And those who are over the age of 80 actually have slower progression than younger patients. And so that's really helpful to know. So when I'm facing someone who has a GFR of 17 and they're 82, doing conservative therapy, I don't even think that's going to impact his mortality at all. It just helps me take better care of him from a more conservative perspective. And I always bring up Art Buchwald. I don't know, who knows Art Buchwald in the audience? Mostly the older folks? Okay. So Art Buchwald is a famous American writer who had advanced kidney disease and went into the hospital with an ischemic lower extremity. And they said, we're not taking off that leg. You're going to have to start dialysis. And so he did. He got the amputation, he started dialysis, and after 2 weeks he said, you know what, this is the birds, I'm stopping. And he stopped, and he put himself on hospice, and was eventually kicked out of hospice, and he lived 10 more months. And so Art sort of epitomized what we see in Ann O'Hare's data. He also wrote about it, Too Soon to Say Goodbye, which I would recommend as a good read. So you'll notice that these people, choosing conservative care is not choosing death. It's actually choosing a different kind of life. So other reasons to consider conservative care, symptoms and quality of life. So patients who elect conservative care have just as many symptoms as those on dialysis. However, they're more likely to be treated. They get symptom support. They get services. They've looked at life satisfaction scores between those who choose dialysis and those who choose conservative care. And for those who choose conservative care, they tend to stay the same. And this is a general measure of well-being. whereas in dialysis, after starting, they tend to drop and they stay dropped. Other folks have done small studies looking at functional status, and surprisingly, patients who elect conservative care are quite mobile or functionally active up until 2 months before their death, so they live well. End of life is less likely to be in the hospital, and they're more likely to receive end-of-life care. When we think about who to talk about conservative care with, there are some folks to think about. I have elderly age with a star next to it because I don't think you should just be thinking about elderly age. Oftentimes what we know in the data we talked about earlier, it's older age and limited prognosis by other comorbidities. There was data that looked at just the year 80 and above in Dutch, and some Dutch literature, and they didn't see a difference in survival independent of comorbidity. But I often think about comorbidities, and specifically cardiovascular disease, poor functional status, malnutrition, and no to the surprise question. How many of you have ever asked a surprise question? Would I be surprised if this patient passed away in 1 year? That question alone has prognostic weight to determine, would this patient actually do well, and is this a patient that I should take a step back and talk with? So that question alone, answering no, should be a red flag in your mind. Other things like geriatric syndromes, they tend to get worse with dialysis. And sometimes it's hard to tease out because some of the symptoms that we may find with geriatric syndromes also overlap with those of uremia. And so it's keeping that in mind. I have an 82-year-old gentleman right now that I am not sure what the overlap is, and he's electing to do a trial of dialysis to see if it improves. So sometimes you don't know, but it's a red flag. Poor quality of life unrelated to kidney disease, as we talked about before. How to talk about it? I think as physicians, we are invested in our expertise, and so we often talk treatment talk. And when we think about treatments that there is no exact right answer, right, because there's uncertainty, we need to step back and think about it in a different way. And we need to think about the patient expertise, finding out what's important to them to figure out, well, what is my treatment most likely going to help with or do for my patient? And so what we teach and what we try to do is actually take a deliberate step back and say, to get a better sense of what is right for you, I'd like to spend some time learning about what's most important. Would that be okay with you? So by asking that question, I have shifted from me becoming the expert to my patient being the expert. And by naming it that way, it makes it sound like there is no real right answer. And it lets them know that this is going to be a difficult decision either way. And then taking time to learn about our patient values and priorities. I often start with, what do they know about their health and how do they see their future? So what has been your experience? How do you see your health? My trainees all ask that question, and they find it so helpful because often our patients are seeing the same things we're seeing, and they'll say stinky. And then I can say, yeah, I'm seeing that too. Can we talk about what's most important given how hard it's been? So just by asking how they see their own health, it's an open door to have a larger conversation. And it's learning about what's important. And when I say learning about what's important, it's making it relevant to where we are in the here and now. So I will say, given your condition, given how things have gone, what's most important to you? What are you hoping for? As you think about getting sicker, what worries you the most? These are the valued data that helps me understand where should we fall in terms of treatments. And oftentimes it's not clear-cut. Patients have a variety of values, just like we all do. And so it's helpful to think about what are the trade-offs, especially as we talk about life-prolonging treatments. It could be chemo, it could be inotrope therapy, it could be dialysis. So starting this life-prolonging treatment, what are situations in which you don't think it would be helpful? That really helps me begin to outline what a care plan looks like. And it's proposing a plan that matches those priorities. And so for folks whose goals are to focus mostly on their quality of life and they're willing to trade added time, and that's potential added time, conservative care is right. For those patients where it's not so straightforward, they have a mix of values. A trial of dialysis with a goal of achieving those values is helpful, and learning what those trade-offs would be and the burdens they're willing to go through for added time. And so that is a framework that we try to ensure that we're matching our treatments with our patients' priorities and ensuring that we're bringing up conservative care. I don't tell a person to do conservative care. I'm putting it in the mix, and I'm also ensuring that I understand their values and preferences. I want to talk now about how do we check in on our patients, especially when they're choosing life-prolonging care. How do we check in to ensure we address symptoms, needs, and prepare for the future? Why does this matter? I'm going to tell you, for the most part, many patients, and I'm talking about patients that we worry won't do well, they do choose dialysis, just as many patients choose chemotherapy. And it's not a bad thing. It's actually quite natural. Many of our dialysis decisions, they come up in the hospital with you guys, medicine residents, and they're in the setting of acute illness. And oftentimes, dialysis looks a lot better than the default, which is death. And so they try to make the best decision they can, and oftentimes they elect dialysis. There's uncertainty about how they do, and people respond to uncertainty with optimism. And that's okay, because we need experience to shape how their experience goes, and that we have to see them over time, because not only their needs will change, but also how they view their preferences will change over time. And so it's thinking about how do we take care of our patients after they choose this life-prolonging care when they may not do well, and why does it matter? So if I choose conservative care, I'm more likely to get my symptoms managed. I'm more likely to have advanced care planning. I'm going to have great services, and I'm going to have a quality end of life in a home-like setting. That is the majority of patients who choose conservative care. For my dialysis patients, as you saw from earlier data, they're not likely to have their symptoms managed, and they're not likely to be prepared for the future, and most of our end of life occurs in the hospital. And so I want to take a moment to just step back and learn our lessons from oncology. So oncology has taught us that you can apply palliative care to life-prolonging therapies, and it improves patient outcomes. And so Jennifer Timmel did an amazing study that's had a lot of articles since then in 2010, which looked at palliative care plus chemotherapy in metastatic non-small cell cancer compared to just chemo alone. And what she found was that palliative care helped with depression and quality of life. And not only that, these patients actually lived longer in the palliative care group by 2 months. And so it brings to mind that adding palliative care does not mean adding death. It just means adding quality, adding symptom control. And so the way I want to think about it, and the way I want us all to think about our therapies, is to not even think about what treatment they're on. Just think about taking care of them and trying to think about active ways to do symptom control, advanced care planning, and address their needs over time to improve a quality end of life. And the way that we've been thinking about that is to have these deliberate moments where we just check in. And it sounds very simple, but it's just not happening. And so what we think about is just like starting a new medication. How many of us would start a new blood pressure medication and walk away? No, right? Because we want to make sure they're not having hypotension. If it's an ACE inhibitor, I sure don't want them to have hyperkalemia. So we are going to go back and check in, make sure they don't have a cough, make sure they don't have side effects. Why aren't we doing that with our life-prolonging treatments? And so I want to view dialysis like a new medicine. And so by checking in on how it's going, I'm being proactive. I'm not waiting for the other shoe to drop. I am just checking in because I am looking for needs that are unaddressed. It's responsive to the treatment plan. I can make changes. I can improve their experience. And hopefully it's patient-centered. And so when I think about a check-in question, it's very simple. And I think about 3 months, because 3 months is when we consider someone a chronic dialysis patient. So it's been 3 months since we started dialysis. Can we check in to see how things are going? What have you noticed? And when I ask that question, I am open to hearing about unmet symptom needs. We may have a conversation about their experience and how they see the future. and we can readdress the treatment plan depending on where the patient is. So by asking this very open-ended question, I'm able to better figure out what my patient's needs are. Do they need services? Do I need to reassess medications? Do I need to reassess my treatment? And it's also helpful to use check-ins as recognizing early signs of decline. We have a 6-month mortality prognostic tool that's available online, and this is called, this was developed by Cohen and authors, and basically it uses 5 variables. It brings up that surprise question that we talked about earlier. Would I be surprised if this patient died in a year? And albumin, age, dementia, and peripheral vascular disease. I don't use this prognostic tool as the Bible. I basically use it as a way to say, should I step back and ask this patient how things are going? I also look for other signs. Medicine residents, you're seeing these patients. Patients who are coming in and out of the hospital. Patients who have other coexisting conditions that are worsening. Patients who are showing me failure to thrive, functional status decline, and quality of life diminished. These are folks that I want to step back and do a more in-depth check-in conversation about how things are going. And what this is really doing is advanced care planning. Advanced care planning often gets thought of as documents, but it's really just conversations. And the fact that it has to happen over time. And it happens with patients' families when they have a chance to reflect on their goals. So cognitive impairment is so prevalent in my population. It can be up to 60% in dialysis patients. 1 in 5 dialysis patients withdraws from dialysis at the end of life, and they're not the ones making the decision. It's their loved one. And so advanced care planning helps me have that conversation earlier so that I can support that surrogate and remind them of goals when I have to have harder conversations. And so for our medicine residents in the room, I want you to see patients that aren't doing well and just ask a simple question. How has being in the hospital impacted how you think about the future? Find out how these experiences are helping them think about their preferences, because it changes over time. And the benefits of advanced care planning is we tend to give therapies that are concordant with goals. Our caregivers have less psychological distress when they've been able to feel good about the kinds of decisions they have to make, and they're more likely to have quality end-of-life care. So looking back at Henry, the things I would have done, I would have offered conservative care. Not that I would have told him to do it, but just that he would have been able to make a decision. I would have checked in to find out if there were some early symptoms. I didn't know what to do about his pain related to his amputations. I felt helpless. So now I could at least check in and find services that could have helped him. I would have looked at those hospitalizations before he became cognitively impaired as opportunities to talk about his goals. And I would hope that we could have had an end of life that was concordant with his goals and that his family felt better. That's who I often think about, is how his family coped. And it's creating a sustainable model. I don't have to tell you this, but there's really not enough palliative care doctors to take care of seriously ill patients. And so Tom Quill and Amy Abernathy have wrote a lovely article in the New England Journal of Medicine, and they're like, guess what, guys? It's up to you, okay? There are 2 different kinds of palliative care skills. There's primary and there's secondary. And primary palliative care skills, every physician should be doing. And I'm talking about surgeons too. Believe me, we're teaching them. We should be able to manage pain. We should be able to manage depression, anxiety. We should be able to have general conversations of prognosis and end-of-life goals of care. And give us a call when it gets more sticky, when there's refractory pain, when there's more complex symptoms, conflict, worries about futility. This is when palliative care should be called. And so I want to spend the last 5 minutes just telling you about what we're doing to instill primary palliative care skills in nephrologists, and mostly through education. This is how I've spent the last 7 years of my academic time. So we've developed NephroTalk, as Dr. Page mentioned in the beginning. It's communication skills training. This is an annual 3-day training that is developed over the past 5 years that's dedicated solely to communication. It's first and second year fellows. All of our first years go, but now we have folks from other institutions who join NephroTalk. And it's structured with small group and large group didactics, and facilitators are palliative care and nephrology educators from Boston and beyond. We are specific about making it an off-campus location, so they don't have to do any clinical work. We make them take off their pagers. They're not on call, and we want to work their weak muscles, and that's their communication muscles. We have short didactics, and we teach communication skills about bad news, goals of care, transitions, conflict, which comes up a lot, and end-of-life care. And we always follow it with a faculty demonstration to show them what the skills look like in action. Most of our time is spent practicing. So we have standardized simulated patients, I should say, with cases. One is an elderly gentleman with comorbidities who's thinking about conservative care. And another is how to talk about a time-limited trial with a seriously ill patient with AKI. And we really use adult learning principles. And so each fellow will volunteer to role play, and we ask them, what do you want to work on? What do you want to get better at? And their fellows help them when they struggle and they feel stuck, and we come up with strategies together. And all of them walk away with something new. What did they learn from that encounter? In the past couple of years, we've been measuring NephroTalk, and so we actually have fellows who do a pre- and post-OSCE. I think our residents remember OSCEs maybe better than some of the attendings, but these are clinical encounters that were audio recorded, and we evaluated them using a bad news checklist. And this was a validated palliative care checklist that was published by Gelfman at Mount Sinai. And then we have two evaluators who are listening to these audio recordings and evaluating whether they completed the skills or not. And then we assess them for reliability. And we only have half the data. I've done 50 audio recordings, and we've measured 24. But this is the data, and it doesn't pick up as well. But what we found is that out of our 9 skills, the blue is post and the yellowish is pre, that all of them improved their percentages in using these communication skills. We didn't have enough numbers for statistical significance for all of them, but we're hoping so. But we had 3 emotion cues that were all statistically significant after training. And on average, these fellows picked up about 3.5 new skills out of the 9 skills that we measured. And that evaluators could actually 94% of the time say, you know, this was definitely a pre and this was definitely a post. So they were very accurate in guessing. When we're analyzing the cohort and hopefully going to publish it this year. Through the William and Sandra Bennett Scholars Program that Dr. Page mentioned, we've been thinking about education in a different way. That, you know, doing these one-on-one trainings with fellows is time-intensive, it's resource-intensive, and we often don't see them again, so how do we sort of build on skills? And so we've been thinking about other ways of doing education, and so I developed an online curriculum, and I'm focusing on conservative care that will go to nephrology fellowships and actually bring the education to them in a different kind of way. So I recently completed an 11, and I say 11 very heavily because it was hard, 11 video conservative care curriculum. And it's got different parts of it that I'm going to walk through with you. The first half of it, we basically do what we did just now, and we talk about what conservative care is. And so we have a video that gives them some of this information in an engaging way. We also have a worksheet that fellows work through, and they have questions. So on average, how long do you think a patient with stage 5 kidney disease would survive without dialysis? And then we check in on their answers later. And the best part about it is we have 2 simulated patients who actually serve as models throughout the curriculum that fellows get to meet, understand their perspectives, and then actually think about them from prognosis and then how to talk to them. So this is one of our patients named Rita. And then we teach them how to talk about it. We teach them a 3-step framework about how to identify patients, how to figure out what's important to them, and then how to make a recommendation. We use their worksheet to let them actually practice coming up with prognosis using one of the tools that I just showed you. And then we teach them a communication framework. It's called REMAP. It's based on Vital Talk, nonprofit. And then we have them practice it. So we have 2 videos where they can actually identify what communication skills we're using. And then we give them the answers. So this is me working with William, the patient. We're hoping to roll this out in academic year 2017 in 4 nephrology programs, so we're looking forward to seeing where that goes. Other training programs that we're doing and many places around the country are doing. I put this up just so that you know we have cardio talk, so heart failure are doing these trainings. Critical care talk. You'll notice there's a lot of talk here. Onco talk, oncology, palliative care talk, goals of care talk. So our hospitalists and our residents all go through goals of care training. And now we have train the trainers, which is basically teaching our attendings how to have these conversations and teach it. I was really excited to be funded by the ASN to teach 12 educators from across the country how to have goals of care conversations, and the best part, how to teach it to their fellows. So this is our cohort, and this is my mentor, Bob Arnold, who has come to speak to you before. But all of these guys are now at their institutions teaching their own form of communication, so really getting out there and spreading the work. So in summary, I want to end with thinking about you and how you're going to create a sustainable model in your practice and in your care. And things that, to think about are, remember the patient priorities and values when you're discussing treatment options. Use a surprise question. My husband's an infectious disease doctor, and he loves teaching his residents about the surprise question. Offer conservative care as an option. They need to know everything so they can make the best decision for them. Incorporate these check-in conversations upstream. Okay, it helps us better treat symptoms and encourage advanced care planning. The last part is the most important part. You all are the front lines. You're seeing these patients. You're probably seeing a lot more critical times than even the nephrologists caring for them. So talk to them. If you're seeing problems, talk to your nephrologist colleagues. Talk to your oncologists. They're probably seeing it too, and they could use your help, and they could also give you some information. So please communicate with your colleagues as you're taking care of these patients. I'm just going to leave you with our 2016 NephroTalk cohort and take any questions that you may have. Thank you.
Thank you, Dr. Schell. We've got a few minutes for questions. I'll ask you to call on the audience and please repeat the question.
Yes. So the question was, for folks who choose conservative care, how much education do they get about fluid, diet, and what was the last thing? Exercise. So you know what? It's really tailored to the patient. So I have, and I didn't talk about my practice as much, but I have patients on conservative care that are different kinds of patients, and it comes down to their goals. So patients who have more time and their goals are more life prolonging, I have them on ACE inhibitors. I have them going to the nutritionist to talk about diet. I give them strategies for exercise. I have other patients that are in a different stage and time is shorter, and I will say I really focus on comfort. I stop EPO, for instance, in patients who aren't moving around because I don't want to keep sticking him for labs. So it really varies, but yes, we're always encouraging living well, and living well can be with diet, nutrition, and exercise. Thank you. Yes? Oh, thanks. Yeah. Right. So the question is, and I'm just going to abbreviate it, and because it's this crisis times when patients are coming in, you don't have a lot of rapport, you have to make a decision for many different reasons. So how do we move from being a default system? And I think that is where we have to step back as a house staff team and think about not, okay, let's order the tunnel dialysis catheter, but hey, let's step back. How do we think this patient's going to do in general? And I think that's where we have to be deliberate about having a goals of care conversation. And it's establishing rapport fast. And some of these tools help us with that by just trying to learn who they are as people. And I got to say that a lot of times they try. And if the care is already moving in a certain direction, it gets really hard to turn it around. So I get called as a palliative care physician right after the nephrologist who's already said put the line in. And I think, so what will it look like if it doesn't go well? So then I just try to have them hypothetically think about. But I think the step back and having a larger conversation, we usually have time for that. We usually have a day or two for that. Thank you. Yes? So the question is, how do we reframe some of the patients' requests when they want the fix, and how do we make that into a more constructive conversation? And those are really hard. I think part of it is trying to find out what are the emotions behind that, because sometimes when we're asking for the fix, there's something underneath, and it may be emotion, it may be cultural, it may be religious, it may be family. So that's my first step, and then when it's clear that they really are very focused on some unobtainable, or what I believe unattainable goals, I really try to do some hypothetical thinking with them. I name that it's really hard, and I say, could you imagine getting sicker? And most people could, and then I'm able to have a larger conversation, but some people can't, and that's when I think, wow, that's a person I really got to check back in on. So really hard. Thanks. Thank you all, guys, for your attention.
I want to thank Emily for identifying Dr. Schell, and I want to thank Dr. Schell for just an outstanding Grand Rounds.